Good afternoon, everyone. I'll be talking about choosing the right patient and the right sized ICL, giving more emphasis to the sizing. So no financial disclosures. So the right candidate. So patients should be aged between 21 to 45 years. Their refraction should be stable, which means that they should not be beyond more than 0.5 diopters change within the past 12 months. So it corrects myopia. So I'm talking about ICL particularly. It corrects myopia from -3 to -20 diopters, hyperopia up to +10 diopters, and astigmatism up to 4 diopters. Patients should have an adequate anterior chamber depth, which should be measured ideally from the endothelium. Ideal would be a 3 millimeters ACD depth, but a minimum of 2.8 cutoff should be respected. So patients should have healthy eyes besides refractive error, and one should rule out moderate to severe glaucoma, active uveitis, cataracts, or retinal detachment. So contraindications, of course, would be a shallow anterior chamber depth of less than 2.8 millimeters, shallow anterior chamber angle as measured on gonioscopy less than grade 2 would also be a contraindication, pregnancy or lactation, uncontrolled diabetes or autoimmune diseases, and also eyes which are not meeting appropriate endothelial cell density criteria, which has been suggested by ICL, by Star Company, and this should also be followed. So coming to the sizing, now conventionally if you see, ICL sizing has been determined basically on the basis of the horizontal wide to wide diameter and the anterior chamber depth. So these variables are then entered into the manufacturer's nomogram, which is available, and this is the OCOS nomogram which is used. So with the wide to wide and ACD, basically the wide to wide is an external measurement that is serving as a surrogate for the internal ciliary sulcus. Now the ICL is actually sitting in the sulcus, but manually from outside you cannot measure the sulcus, so wide to wide serves as a surrogate for that, and it is based on the assumption that the sulcus size is 0.5 millimeters larger than the wide to wide, so it accounts that and calculates the lens power. Now where the fallacies arise, this could be first and foremost, it could be just a measurement error. Now, considering that the limbus itself is a 1.5 to 2 millimeter gray zone area on both the sides, it itself can introduce an error of up to 4 millimeters if it's not measured correctly. And the measurement would also depend upon how and from which point are you measuring the wide to wide, the inner or outer limbus, which is selected as a starting point. So for best reproducibility, it is advisable to measure the limbus from mid-gray zone on one side to the mid-gray zone on the other side. So that is with manual caliper. So the manual calipers have, of course, some advantages, that it's low cost. However, the accuracy can suffer. So now you have the digital calipers also. With the digital caliper, the accuracy is better. However, both the methods are operator dependent and thus can have subjective variations. Now, we also have automated systems such as the OpScan 2, the IOL Master 700, the Pentacam, and now the MS39. Now, the advantages of these automated devices is that they provide high precision readings, and they are less operator dependent and provide much more comprehensive data alongside the wide to wide value. But of course, they are expensive and there can be device specific biases also. Now, if you just compare the average values of wide to wide measured using the different ICL sizing methods, using the different techniques of measuring the wide to wide. So the manual method of Castrovizio caliper, it actually gives you an average value of around 11.94, which is the largest amongst all methods. The digital can be slightly smaller than the manual. The Pentacam actually gives you the smallest mean of all. The IOL Master gives you a mid-range value. The MS39, which I am currently using, is actually, if you see, is quite close to the value provided by the digital caliper. And the OBSCAN, of course, is considered to be very accurate, but now because it's not available commercially, so the availability is limited. Now, what was the need for newer ICL formulae? Now, there were some limitations with the traditional methods of white-to-white calculations. And this is, as I said, the white-to-white does not directly measure the sulcus diameter, which is the actual space where the ICL will be implanted. So this can lead to potential inaccuracies in the sizing. And so you can have post-op vaulting issues, either a very high vault or a low vault. And also it has been found in many studies that the correlation between the white-to-white corneal measurements and the internal sulcus to sulcus is also weak. Basically, it's not that if you predict the white-to-white and if you measure the white-to-white, the sulcus to sulcus will always be 0.5 diameter larger. So that's not the case in every eye. So they do not correlate very well. Sometimes it can be smaller also. So you can end up having unpredictable outcomes. So the success rate with the star Oko's formula has been found to be 66.4%, which means that you can get a vault of the accurate size, which is 250 to 750 microns, in about 67% of the cases. However, about 33% of the cases were shown to fall outside this normal range. Also, why new formulae were developed? This was because there were advances in the imaging technologies. So now we can measure direct sulcus measurements through anterior segment OCTs, through UBM, and now we have also some new parameters such as the crystalline lens rise. So when you use only the white-to-white and with the Oko's formula, there could be some eyes where you could have some, red flags. So you should be very careful in these eyes about selecting the size. So these are extremes of the refractive errors: high myopia, high hyperopia, extremes of the chamber depth, very shallow and very deep chamber depths, irregular corneal shapes, post-refractive surgery eyes, post-LASIK, post-PRK, ethnic variations, thick or highly curved crystalline lens, which is the high crystalline lens rise, or the CLR, very narrow or wide sulcus angles also, and as well as pupil size extremes or decentration. So if you encounter any of these conditions, so you need to be much more careful if you're using the conventional method. So the clinical implications in these eyes could be, if you see the vault error magnitude, a 0.5 millimeter ICL size error would actually shift your vault by 200 to 300 microns. And if these are red flag eyes, this could actually push it to outside of the normal range, and you can end up getting a very low or a very high vault. So the success rate of the Oko's formula, which is 66.4, will actually drop further in these extreme conditions. So what is recommended is that in these eyes, it's better to supplement the white-to-white with the direct STS, which you can, of course, measure with the UBM, or the angle-to-angle, which is measured using the OCT, and CLR and some of these newer biometric methods, and using the modern formulae. Also use better screens better tools for screening, such as the preoperative OCT like Anterion, MS39, UBM, or shine plug imaging, to identify these eyes with red flags for proper sizing. So this is a picture showing UBM sulcus to sulcus. So UBM is high frequency UBM with wide scanning field. It enables the direct measurement of the ciliary sulcus. And this is how the anatomy of the ciliary sulcus looks like with the UBM. So you can see the white-to-white on top and sulcus to sulcus. So you can see actually in this eye the sulcus to sulcus is wider, but this is not always true for every eye. So crystalline lens rise, or CLR, or simply the lens rise, is nothing but it is another biometric measurement that quantifies the anterior protrusion of the natural crystalline lens in the eye relative to a reference plane. So what is this reference plane? This is essentially the line connecting the angle recesses or the sulcus to sulcus plane. So you can see on both sides, the sulcus to sulcus, there is this line that joins, and in reference to this line, how high your lens is, the crystalline lens is. So based on these new parameters, you have now many new formulae, such as the KS formula, the NK formula, SN formula, the Lasso suite, and the WH formulae. So most of these newer formulae have actually shown that the success rate of achieving successful vault is comparatively much higher compared to the star OCOS formula. Why not 100%? Why we do not get 100% successful vault in all eyes? That's because even with the newer formulas, you can still have some variations which may be related to measurement inaccuracies, unpredictable anatomical variations. They can be post-operative changes, where the haptic settles, healing, formulae imperfections, formulae are still getting refined, and surgical and anatomical clinical variables. So even with these high success rates, 15 to 20%, 25% of the cases will still have irreducible challenges. However, if you use real-time intraoperative vault measurements, and also if ICLs are available in finer increments of, let's say, 0.1 mm, that might push the rates closer to 90 to 95%. So choosing formula, choose the proper demographics, because not all formulae are for all ethnic races. And also if the patient's age at the time of ICL implantation should be considered. So those factors, those formulae where CLR is used, so that the CLR may continue to increase over time due to natural lens aging. So this should also be kept in mind. So my protocol briefly, I'm using now MS39 because MS39 is highly accurate for white to white measurements with a repeatability error of only 0.05 millimeters. And it agrees very well with the devices like Pentacam, which most of the surgeons are now using, the accuracy being within plus minus 0.2 millimeters. In irregular corneas, however, the accuracy can slightly vary, but still remain strong with the variation of within 0.2 millimeters. So this case had a white to white of 12.61, and I just used this reading. And with the OCOS formula, it suggested a 13.2 lens, and the post-op vault is 596, which is very much within the normal range. Similarly, this patient has a white to white of 11.9, and with the regular star formula, I achieved a lens, the vault of 600 microns, which was fine. So to conclude, basically all currently employed methods, including those based on white to white, STS and ATA, for predicting vault and selecting ICL sizing, produce acceptable results. However, with the newer formulae, experienced surgeons should investigate their personalized methodology, what works best for you for patient evaluation and ICL selection that best aligns with your personal preferences based on your experience, which formula you feel is giving you the better results, what diagnostic technology you have for white to white and other biometric assessments, and also what analytical tools you are familiar with. So it has to be a personalized methodology for every patient. Thank you so much for your kind attention.
Thanks, Pooja, for that wonderful talk. Meanwhile, I'll request Dr. Pooja to be there on the stage. Any quick question for Dr. Sheetal? Can I have a question, Sheetal?
Dr. Sheetal, I think excellent presentation. A couple of points I'd like to mention, especially when you talked about the CLR. I remember we were one of the first people 11 years ago pointing out that this could be an important component. Yes. Because one thing I've noticed is yesterday also in a session, a suction course, we had a patient who had a great vault, but the lens would keep rotating. Patient had a vault of 600, the lens rotated. We changed the lens, put a 900, lens rotated. And that's when I went back to the drawing board and found there was a CLR of negative. So these are the patients you should look out for, where your CLR doesn't go into the minus because the lenses will keep rotating.
So then some of these newer formulae, they are available in Anterion and KZR2, the NK formula.